I am also orthopedic surgeon. I have three interests. One is MSK ultrasound, and I am a foot and ankle surgeon and sports physician. And these three is my today's lucky number, so you will see a lot of three in my presentation today. And this visit to Taiwan is a second time for me, not third. My first visit was 3 years ago with our boss, Dr. Minagawa. My first visit to Taiwan was fantastic because of Dr. Hu and Dr. Wang and everyone. So it is a great honor to give me this opportunity to speak in Taiwan again. So I'm really looking forward to come here, but yesterday morning I was given an IV of antibiotics. I've got a fever because of my tonsillitis from Tuesday. And the fever about 39 degrees continued for 3 days. But today, I think my desire to go to Taiwan has lowered my temperature. Thank you for letting me know. My today's topic is scratch clap test for hide release for lower leg. But there are very few studies about scratch clap test in lower leg. I can find only one. So today I want to talk case presentations and some knocks and pitfalls of hydro release. First case is popliteal pain. She is a 19-year-old cheerleader and she injured her left knee pain. Initially, hyperextension. After hyperextension, she felt lateral popliteal pain here. And now, 2 months, she suffered this pain for 2 months. And now she suffered deep knee flexion pain. Deep knee flexion is something indirect nerve compression test for common peroneal nerve. So I can check the common peroneal nerve by ultrasound. Common peroneal nerve here, and she had tenderness around here. So I check the scratch collapse test for common peroneal nerve. LC side, and of outside. Yes, so I think positive. So I performed hydro release for common peroneal nerve. Peroneal nerve here. And next target is above the nerve. After hydro release, scratch collapse is negative and she can deep knee flexion, less pain. Next case is almost same. Soccer player, and he felt pain same area. So I hydro release his common peroneal nerve. After hydro release, he can deep knee flex. Next patient is same. she cannot crouch because of her bilateral popliteal pain. So I had released her bilateral common peroneal nerve. She can crouch and stand without pain. Her chief complaint was deep gait disturbance due to muscle weakness around here. And she had tenderness around common peroneal nerve. So I had released her common peroneal nerve. She can walk more smoothly after hydro release. And she said the muscle weakness recovered. So I think common peroneal nerve disorder is very common injury, and hydro release is very good option for such condition. Next case is ankle pain. This is a 36-year-old man, and he played football, and he had an arthroscopic ATFL repair 7 months ago. And 4 months after surgery, he returned to play football. But 4 weeks ago, he felt right ankle pain around here, and he was consulted by another doctor and took painkiller for 3 weeks, but still now his pain remained. He felt tenderness around here and pain on running and stopping while playing football around here. ATFL is here, and his ATFL is good repair. So I checked ultrasound around this area. He felt pain around here. How do you think his condition? Muscle removed, you can see the artery and nerve. So anterior tibial artery and deep peroneal nerve. I think this is his pain causes his pain. So scratch collapse test out for deep peroneal nerve. Deep peroneal nerve area is here, so I scratch this area. You cannot see, but I scratched this area. Weakness, positive. So I released deep peroneal nerve by saline. Sometimes usually I can see deep peroneal nerve lateral to the artery, but in this patient, medial. After hydro release and scratch collapse test. Negative. And after this hydro release, he could play football without pain. Without pain. So the third case is residual ankle pain. She is 40-year-old female nurse, and she sprained her right ankle while walking, and had the US exam 1 week after surgery by me. This is ATFL view. This still image looks normal, at first glance, but until lower stresses are applied, you can see rupture side and instability here. This is rupture side. 1 week later, so partially covered. Next, I will check the calcaneofibrillar ligament and subtibial joint. This is short axis of calcaneofibrillar ligament, thickened, and long axis DFL damage, and subtalar joint is here. You can see hematoma of the subtalar joint. So my diagnosis is ATFL injury, CFL injury, and subtalar joint injury. So my treatment plan is ankle brace for 3 weeks. But 4 weeks after injury, she still wear an ankle brace because of severe right ankle pain. ATFL. You can see good continuity and no instability. So ATFL is in good condition. Subtalar joint. But she still had subtalar joint diffusion so much, so puncture. Below serous 1 cc, and then I injected lidocaine and dexamethasone. After injection, her weight-bearing pain was decreased obviously, but 2 weeks later, she still suffered her right ankle pain around ATFL. 6 weeks after injury, I think it's good condition. But in Canal Doppler mode, you can see so much blood flow around the ATFL, so I thought there was inflammation. Then I injected lidocaine and dexamethasone around ATFL. I also injected ankle joint and above ATFL. After this injection is also effective, but pain still remains. So I checked MRI to rule out osteochondral lesion, but I cannot find out osteochondral lesion. X-ray also negative. So I asked her again, what motion is most painful? She said it was hard for her to crouch and heel raise because of anterior ankle pain here. So I checked by ultrasound around here. I finally I found out the lesion by this examination. Can you find abnormality? Again. Can you find it? Yeah. The upper side is an injured side. You can see thickened tissue above the ATL. Long axis, injured side and injured area. So this tissue is inferior extensor retinaculum, and nerve should be considered. Medial dorsal cutaneous nerve and intermediate dorsal cutaneous nerve. These are the branches of superficial peroneal nerve. And this patient had LDCL. You can see the medial dorsal scutal nerve here. You can see the nerve. Again, you can see nerve runs through about the thickened reticle. So this pain should be a nerve compression test for medial dorsal scutalis nerve. So I checked scratch collapse test for medial dorsal scutalis nerve. Scratch. Positive. So hydro release for medial dorsal scutalis nerve and inferior external retinacle by using out of plane technique. And I injected hyaluronic acid. Nerve is here. After hydro release, I confirmed release the nerve and scratch collapse test. Negative. Nerve compression test. She said pain decreased after injury. So sometimes inferior external retinacle and medial dorsal scutal nerve is causes of anterior ankle pain. This is another case. After ankle sprain, she had ATFL and CFL injury. After 2 weeks injury, you cannot find out no thing, so you cannot find out retinacle. But 4 weeks later, you can find a second retinacle. I think key elements of hydro release, successful hydro release is mainly two. Accurate. Sorry. One is accurate diagnosis using ultrasound, and another one is accurate injection using ultrasound. Ultrasound guided injection can be classified into two groups: out of plane technique and in plane technique. Today, I want to explain technical tips of in-plane hydro release. Before I talk to you about these techniques, I have to introduce three gods. First one is C. Her name is you know Judy Ong. Judy Ong is from Taiwan. I love this song. And his book, Dr. Nakanishi's book, is this is a still image from the movie of this book. This is actually black plexus block. The target is medial nerve, radial nerve, and ulnar nerve. Can you block ulnar nerve and make donut sign ulnar nerve here? I think very difficult, but he did it very easily. So this is Japan quality. Please read this textbook, but unfortunately, all written in Japanese. So I want to explain technical tips of in-plane hydro release. First one is inline. Visual line to the monitor should be ahead of the visual line to the probe. So we call this inline. visual line to the monitor and probe is same. It's important. Second, you should always visualize the needle tip. This is a hydro release for C5 and 6 knob. Needle here, target is here. Do you think needle tip is this? The answer is sometimes no. Knob and probe. Only the needle in the area can be seen by ultrasound monitor, but the actual needle is often there, so needle tip is sometimes here. So if you cannot see full length of needle, like this, look away from the monitor and you should check the angle between probe and needle. Then adjusting using rotation and sliding technique. You cannot find full length of needle, so rotation and sliding and then go. Rotation and sliding and go. This is safe technique. 3. Use bevel up and down properly. Needle tip direction above is bevel up, and the needle tip direction below, we call this type bevel down. This is the hydro release of ulnar knob here. First target is below the knob. Do you use bevel down? Bevel down? There is a risk of puncture the funicle, so bevel up is the correct answer. So, at first, visualize the full length of the needle and using repetitive sliding scan, and below the knob, bevel up, and then the target is changed above the knob, so I can change bevel down and consider bevel up or down properly. It's very important. Today I introduce 3 goals, but there are more respectable people than them. Taiwan people. 8 years ago, we suffered from Great East Japan earthquake. 2 big earthquake, tsunami, and Fukushima nuclear accident. So many people dead. So many buildings collapsed. On the other hand, so many foreign people help us. This data is that our boss, Dr. Minagawa, often uses. Taiwan helped us as much as the United States. All of Japanese really appreciate grateful support from Taiwan. So my conclusion slide is thank you for the attention.
Thank you very much for your wonderful talk.